Hello, everybody. Welcome to the Society of Surgical Oncology 2017 breast webinar, Breast Cancer in Women Over 70. The moderators for today's program are Drs. Gretchen Arendt and Dr. Susan Bubel. The case presentations will be conducted by Drs. Celia Reyes, University of Pennsylvania, Abby Gillespie, Women and Infants, Arsalan Salamat, University of Pittsburgh Medical Center, and Allison Barron, Mayo Clinic. We encourage all participants to call in using the phone number and passcode in your registration email so you can actively participate in the discussion. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. You may also send questions at any time by using the Q&A window located on the lower right of the presentation screen. Just type your question at the bottom of the Q&A box and press Ask to send it. A brief discussion session will follow each presentation. I will now turn over the call to Dr. Arendt, and we can now begin.
Okay, welcome everybody. This is a very timely topic because, as we know, the population in our country is aging, which means that managing breast cancer in women over the age of 70 will become more common. And clinical trials frequently do not include many women in this age group, so data regarding appropriate management and outcomes are generally retrospective rather than prospective. We want to avoid either overtreating or undertreating, but there is literature that says that there is a disparity in outcomes for our older breast cancer patients. So tonight's discussion is to look at women over the age of 70 who present with biologically favorable breast cancer, clinical stage 1 hormone receptor positive breast cancer, to discuss whether radiation therapy should be recommended and whether sentinel node biopsy should be performed. So we will start with the first scenario, which is radiation therapy is recommended for local management of stage 1 ER-positive breast cancer in women over the age of 70. Dr. Celia Reyes from University of Pennsylvania will argue the pro position. And following her presentation, Dr. Abby Gillespie from Women and Infants will argue the con position, and then we'll have time for questions and discussion. So I'll turn it over to Dr. Reyes.
Okay, thank you. Can you all hear me?
Yep, go ahead.
Great. So, control the slides. Great. Okay, so I'll start with a brief case presentation followed by a review of data and tools that aid us in this treatment decision. Our patient is a 71-year-old female who initially presented with no breast-related symptoms. Her routine screening mammogram demonstrated a spiculated mass in the outer left breast. Diagnostic mammogram and ultrasound confirmed this to be 17 millimeters in largest diameter. A core biopsy showed invasive ductal carcinoma, ER and PR positive, and HER2 negative. In terms of her history, she had no significant acquired risk factors for breast cancer, as you can see listed on the slide. She did, however, have a strong family history of breast cancer in both sisters. One of them was diagnosed at the early age of 29, and she had a maternal cousin who also had breast cancer. As a result, she underwent genetic testing, and there were no deleterious mutations found. Her past medical history was significant only for GERD. She had no previous surgeries, denied tobacco, alcohol, or drug use. On exam, she's a well-appearing non-obese female that was fully active and had no physical restrictions. Her breast exam showed good symmetry with no nipple inversion, discharge, or retraction, no skin changes, no axillary, supraclavicular, or infraclavicular adenopathy bilaterally. There was a small but palpable mass noted in the outer left breast, consistent with recent imaging. And then, here we can appreciate the posterior spiculated mass noted on the outer left breast. on digital mammography. And then, again, the pathology of the core needle biopsy was concordant with the imaging and showed an ER/PR positive, HER2 negative invasive ductal carcinoma. She then underwent a left partial mastectomy with the left sentinel lymph node biopsy. Further final surgical pathology revealed 1.8 centimeter poorly differentiated invasive ductal carcinoma, grade 3 with lymphovascular invasion. All margins were negative. They were more than 2 millimeters. There was strong ER and PR positivity, and it was HER2 negative. 3 sentinel lymph nodes were taken, and all were free of tumor. And of note, her tissue was sent for oncotype DX and found to be 26. So in summary, our patient is a 71-year-old female with a T1N0 poorly differentiated invasive ductal carcinoma, hormone receptor positive, and HER2 negative, grade 3 with positive lymphovascular invasion and negative margins. Her treatment plan consisted of a breast conservation surgical approach. Due to her positive hormone receptor and postmenopausal state, anastrozole was recommended as adjuvant endocrine therapy. And her high-risk features including poor differentiation, high-grade lymphovascular invasion in conjunction with her overall good health and high functional status led us to discuss radiation options. And so here at Penn, we've developed specific pathways that outline our treatment algorithms for breast cancer patients after lumpectomies. The first factors noted here are age and tumor size. For women greater than or equal to 70 years of age with T1 tumors, we determine whether they're good radiation candidates based on overall health and life expectancy. For favorable candidates like our patient, we discuss 3 main radiation options: partial breast radiation, whole breast radiation, or omission of radiation. To be a candidate for partial breast radiation, margins need to be greater than 2 millimeters, must be negative, and there can be no extensive DCIS on final surgical pathology. For whole breast radiation at Penn, we typically implement the Canadian schedule that delivers hypofractionated whole breast radiation in the course of 3 to 4 weeks with a boost instead of the traditional 6 to 7 weeks. We also discussed the option of omission and the marginal benefit radiation may have in certain women. There are some additional tools that can also aid in counseling these women, and I have that on the next slide. Some institutions like MD Anderson have developed nomograms to assist with predicting benefits of radiation for older patients with breast cancer. This one in particular uses factors such as age, race, tumor size, estrogen receptor status, and nodal status to predict the 5-year and 10-year risk of mastectomy in these patients. This can be beneficial in the majority of elderly breast cancer patients, but when you look closer at the data, which I'll do in the next slide, if you look closer at the data that these nomograms are based on, patients with high-grade lymphovascular invasion, like our patient, may not be well represented in these groups. Okay, so the most well-powered prospective randomized controlled trials that address radiation in older women are listed in these first 2 rows. These are the CALGB 9343. This is the trial from 1994 to 1999. And then there's the most recent PRIME 2 trial, which is almost twice as large, and that's from 2003 to 2009. Both trials included older women with early-stage breast cancer that were given endocrine therapy, and they randomized them into 2 cohorts with and without adjuvant whole breast radiation. The CALGB group all had tumors less than 2 centimeters in women equal or older than 70 years of age and were exclusively given tamoxifen, as you can see here where I'm pointing. And then the PRIME 2 cohort was almost twice as large as the CALGB and included women with tumors up to 3 centimeters, greater than or equal to 65 years instead of 70, and accepted either tamoxifen or aromatase inhibitors as adjuvant endocrine therapy. They also included patients with grade 3 tumors or lymphovascular invasion, but did not include patients that had both. as is the case with our patient. It's important to note that even though they accepted high-grade and lymphovascular invasion in this study, these tumors consisted of less than 5% of their overall study cohort. Also, you can see in this column, neither of these studies included information regarding HER2 status, which was not available at some of those dates. Comorbidities, they didn't include comorbidities or functional status, or endocrine therapy compliance, Oncotype DX, which was also not available at that time, or also did not include patients with both high-grade and lymphovascular invasion. Both studies did not find any difference in survival with or without radiation. You can see here the CALGB study did find an improvement in 10-year local regional recurrence from 10% to 2% with radiation. And the PRIME-2 study found a similar improvement in ipsilateral breast tumor recurrence at 5 years from 4% to 1% with radiation. Grade 3 tumors were of borderline significance in this study and could possibly have led to a more significant difference in a larger sample with high-grade tumors. And then I included this third row, which is retrospective data. This is what that previous nomogram was based on. This is retrospective data in CALGB eligible patients using the SEER database that looked at prevention of mastectomy as a surrogate for recurrence. The aim was to assess the absolute risk reduction of radiation on subsequent mastectomy in routine practice outside of clinical trial setting. So that was really wanted to see what are we using, or how is this affecting us in routine practice outside of those 2 clinical trials that I highlighted before. And it really helped identify patient groups that have a measurable reduction in the risk of mastectomy, specifically patients with high grade, those who underwent clinical lymph node assessment, and patients ages 70 to 74. Over here you can see that when you combine age and comorbidities, you can see there's a large difference in the number needed to treat with radiation to prevent a mastectomy within 10 years in patients ages 70 to 74 without comorbidities compared to older patients with comorbidities, and that's a pretty significant difference, the number needed to treat of 21 versus 125. And then also the 10-year risk of mastectomy without radiation in patients with high-grade tumors is almost twice as large as those with low to intermediate grade tumors, which really suggests that grade may be an important risk for recurrence in this population. And so in conclusion, current data addressing radiation in women more than 70 years with early stage breast cancer suggests a marginal benefit of radiation in women with low risk features who are taking endocrine therapy. It does not address recurrence risk in women with high risk features such as grade 3, positive lymphovascular invasion, high Oncotype score, and poor endocrine therapy compliance. Some women may not want to take 5 years of endocrine therapy and would rather opt for a few weeks of radiation treatment instead. Also, current data may underestimate recurrence risk overall because many women who intend to take endocrine therapy for 5 years instead of radiation therapy become non-compliant due to some well-known side effects. We don't know if women in these studies were much more compliant with their endocrine therapy than our general population. And so we conclude that radiation treatment should be included as an option in the shared decision-making process in otherwise healthy women ages 70 to 74 with early-stage breast cancer and high-risk features that are not well represented in large prospective trials. Thank you.
Okay, Dr. Reyes, thank you for that presentation. I would say you've made a very cogent argument that patients with high-grade tumors with other associated risk factors for recurrence would benefit from whole breast radiation because both the PRIME-2 trial and the CALGB trial really would not have included this patient, would not have been eligible. Are you able to go back to Dr. Reyes's slides so that we can look at the algorithm for radiation therapy decision-making again? we can get that back up there. There we go.
This one?
Yes, that one. So what I think this is a good algorithm for discussion because it seems that the decision node here is good or excellent life expectancy more than 10 years compared to fair or poor life expectancy. What I don't see on the algorithm, though, are tumor factors that would be associated with a lower risk of recurrence. So how does your program use this algorithm in a patient who has a good or excellent life expectancy, but with a smaller tumor that is non-high grade, ER positive, no lymphovascular invasion? Do you use the same algorithm?
We do. We really think of this as a shared decision between both of us and the patient. So we talk to the patient about how they do have the most favorable characteristics, and we do talk about the data and what kind of a benefit they're getting. That in those patients it is marginal, and it's really up to the patient whether how important they view a 10% risk, right? A 10% risk over a 2% risk over 10 years. Right, some patients can hear that number and think, wow, that's really high, I don't want to take that risk. And other patients hear the same number based on the CA-LGB data I presented, and will say, I'll take it. I don't want to go through radiation. Other women will talk about how they've heard bad things in the media about endocrine therapy, about the hormone pills, and they don't like the idea of taking that for 5 years. So then we also give them options of not that conventional schedule, which the conventional schedule of radiation is really up to like 7 weeks, and we use the Canadian schedule. So even if we're giving whole breast radiation, we're giving them a shorter schedule, so it's about 3 to 4 weeks. And then some women that you described that are actually very favorable characteristics that are smaller tumors, then we can offer them partial breast radiation, which would really be just 1 week, twice a day. So that's less inconvenient, I think, to the patient. And I think nowadays we really do have better options in terms of radiation to discuss with them. And
I think you're right, it's a shared decision depending on what the patient's endpoints are. If survival is the endpoint, a 4 versus 1% risk over 5 years or 10 versus 2 may not be that important, but if local recurrence is their most important endpoint, patients with that low risk of recurrence may choose radiation. Why don't we move on to the next presentation, which is Dr. Galetsky from Women and Infants, arguing that radiation therapy is not necessary after breast-conserving therapy in this patient population.
Hi, this is Abby Galetsky. Can you hear me?
Mm-hmm. Go ahead.
Yes. Hi. So just like Dr. Reyes, I'll be starting with a case presentation. My patient is JD. She's an 80-year-old female who was referred for new right breast calcifications on screening mammogram. Imaging revealed a 9 millimeter area of calcification at 10 o'clock, 5 centimeters from the nipple. The patient has a long history of benign prior mammograms. She's G4, P4, with a past medical history only of hypertension and hypercholesterolemia. Her only prior surgery was an appendectomy. She lives with her husband of 62 years and denies the use of alcohol, tobacco, and recreational drugs. She had a paternal aunt with postmenopausal breast cancer and no Ashkenazi Jewish heritage, and her physical exam revealed a palpable mass in the right breast at 10 o'clock without skin or chest wall fixation and without axillary adenopathy. My patient is certainly not Betty White. I just wanted you to have someone to picture as we go through this. The patient underwent ultrasound-guided biopsy, which revealed an invasive ductal carcinoma, grade 2, ER/PR strongly positive, HER2 negative. And these representative images include the post-biopsy film with the clip plate. She underwent surgery with a right localized lumpectomy and sentinel node biopsy, and the pathology revealed a 9-millimeter invasive ductal carcinoma, ER/PR positive, HER2 negative, with all margins negative and no nodes positive. So the patient is in your office for her postoperative visit, and she's asking what's next. So if she were in my office, I would counsel her that in women over age 70 with stage 1 ER-positive breast cancer, radiation therapy is not a necessary part of treatment after breast-conserving surgery. And this is why. So my first point is that older women have more favorable tumor biology that is more responsive to hormone therapy. In a study from the Journal of the National Cancer Institute, older women had an increasing association between age at diagnosis and the presence of favorable biology in the tumor, such as steroid receptor, normal p53, and absence of EGFR. And in the SEER registry, the 8-year survival of node-negative patients with tumors less than 2 centimeters relative to age-matched women was slightly over 1 for women over 70, higher yet for women over 75, and 1.09 for women over 80. My next point is that endocrine therapy is very effective at decreasing the risk of breast cancer recurrence and death in ER-positive tumors. In a trial of 153 fit older women with node-negative ER-positive tumors, these women were randomized to primary tamoxifen to the point of disease progression or mastectomy with tamoxifen. And a large number of those receiving primary tamoxifen had complete clinical response. And this study went out to 10 years. And in comparing those two groups, there is very little difference in survival. My next point is that radiation therapy is not without side effects. If you look at the gray bars on these images, that represents women who had radiation therapy. Years after surgery, these women still had retraction and atrophy, telangiectasia, fibrosis, and edema. If you look at the black dots, which represents the radiation therapy again, had continuing breast symptoms, continuing arm symptoms, and decreased mean sexual functioning, again, for years after their treatment. And in this study, in the radiation group, there were 13 deaths at 5 years, with 3 due to breast cancer, and in the no radiation group, there were 16 deaths at 5 years, with 5 due to breast cancer, not a large difference between the groups. And then my final and most important point is that radiation therapy does not improve overall survival. In a 2009 study of 749 older women with T1 to 2 tumors randomized to radiation and no radiation, if you look at the black line, which represents the omission of radiation therapy, there is a slight increase in 5-year in-breast recurrence, but there's really no difference in disease-free survival and no difference in overall survival. To reiterate that point, the CalGB 9343 study showed, if you look at the blue line, which is the group that includes radiation, and the yellow line, which omits radiation, there is a slight difference in local regional recurrence-free survival, but really no difference in mastectomy-free survival, distant metastasis-free survival, and overall survival. And this study was also carried out to 15 years. In the PRIME2 trial of over 1,300 women, and as Dr. Reyes mentioned, this included grade 3 tumors and lymphovascular invasion, there is a slight increase in breast recurrence if you look at the blue line where radiation therapy was admitted. And at 5 years, there were 40 deaths in the group that received radiation, 49 in those who did not. 4 deaths due to breast cancer in those who received radiation and 8 in those who did not. And again, that's not a very large difference when you look at over 1,300 women. In a trial of 627 women, I'll make the point that the size of the tumor really does make a difference, and you really need to consider the population of women in whom you're omitting the radiation therapy. The left side of this figure focuses on those with T1 tumors, and the right side focuses on those with T2 tumors, with the dark line being those that received radiation. And this first figure shows that there's really very little difference in in-breast recurrence and in overall survival. But when you look on the right side of the figure with T2 tumors, there gets to be a significant difference in breast recurrence as well as survival over time. So I could keep showing you these Kaplan-Meier curves, but luckily someone did a meta-analysis. This figure looks at the largest trials of older women receiving radiation therapy, with the left side of the figure noting when tamoxifen with radiation is preferred, and the right side noting where the study would favor tamoxifen alone. And with overall survival, there's really no difference between the groups. So there are several large groups that agree with this stance, including the International Society for Geriatric Oncology, who noted that there's no level 1 evidence for survival advantage in radiation therapy in women over age 70. Additionally, the NCCN notes that in women over 70, I've lost function of my mouse here. Oh, there we go. There we go. Sorry, in women over 70, radiation therapy can be omitted in women with stage 1 ER-positive breast cancer with negative margins who are likely to complete 5 years of endocrine therapy. So the European Society of Breast Cancer Specialists felt that there is no group in whom radiation therapy can be systematically omitted. And I wanted to delve a little bit into why they may have felt this way. And in looking back at those prior studies, we really didn't discuss which of those women may or may not have been adherent to their endocrine therapy. So this study, where the red line is women who were adherent with their endocrine therapy and received radiation, and the purple line is those who were non-adherent to their endocrine therapy. And there were significant differences over time with non-adherence in local control, regional control, freedom from distant metastases, disease-free survival, and overall survival. Additionally, you could argue that looking at those error bars, there's really very little difference in overall quality of life in women who receive radiation therapy and those who don't. But if you look at mean sexual functioning, with the black line being those receiving radiation, there are persistent differences over time, and the writers of the study noted that fewer and fewer women were even filling out the sexual functioning portion of their surveys over time. And when we don't always think about this fact for older women, we really should, and I'd argue that Betty White would want us to. In terms of risk of recurrence, there is a real difference, and this needs to be discussed with the patient population. This meta-analysis again shows all of the dots on the left side of the figure indicating that tamoxifen with radiation therapy would be preferred. However, women who are having recurrences are still opting for breast-conserving therapy. In the CALGB trial, 33 women had recurrences and only 14 underwent mastectomy. And in those electing to have breast conservation, only 8 agreed to radiation therapy. So there are a number of reasons why women may want to avoid radiation therapy, and there are a number of alternatives for them. Just like Dr. Reyes said, hypofractionation, also intraoperative radiation therapy, brachytherapy. But a lot of these trials have been small, particularly in older adults. Only 12% of women in the START trial were over age 70. And many of these are non-randomized trials. So in a almost 300 patient study of weekly radiation versus daily radiation, the patients who were selected had older age and or poor medical condition and or logistics issues, which makes it hard to generalize for your patient populations. And that's not uncommon in these studies. I think we're coming a long way with them. and a lot is changing and improving, so it is very valid for some women. So just to summarize these points, with the European Society, who said that there's no group of women in whom radiation therapy can be omitted, even they felt that in the absence of survival benefit and with the fact that local relapses can be successfully secondarily operated, this portion should be balanced with the need for travel and also the individual preferences of the patient. So to further summarize, radiation therapy is not a necessary part of treatment after breast-conserving surgery in select groups of older women because these women have more favorable tumor biology that's more responsive to hormone therapy, and because radiation therapy causes real changes in quality of life, and radiation therapy does not improve overall survival. Thank you very much.
Okay, that was very impassioned argument to withhold radiation in this group of women with favorable tumors. And I just want to make sure for our discussion that we are comparing apples to apples, since the patient that Dr. Reyes presented was a higher risk patient. I think we should focus our discussion on the patient who has a non-high grade tumor that is less than 2 centimeters, strongly hormone receptor positive and node negative. And I don't know if there's a way for us to poll the audience on the webinar to find out what percentage of the participants would recommend radiation in that favorable setting versus what percentage of our participants would not recommend. Is there a way to do that? Alana?
Give me 1 second and I can get that up.
I guess this is more of a philosophical question, but I think we can all agree that the data support no difference in survival with receipt of radiation in this favorable group. The data also supports that there is a reduction in risk of in-breast recurrence. How high does the risk of in-breast recurrence need to be to strongly advocate radiation? Why don't I ask at Fox Chase, Dr. Mateo?
Dr. Mateo, you're unmuted.
Hi, can you repeat the question one more time? I don't think I heard the last part.
Sure. So, I mean, I think what the data that we saw from both presentations is that there is no difference in survival in women where radiation has been omitted.
Mm-hmm.
There definitely is a difference in breast recurrence, although the differences are relatively small. So is there a threshold where we should always, for risk of in-breast recurrence, where we should always recommend radiation? For example, the PRIME2 study showed that in the non-radiated group, the 5-year in-breast recurrence risk was 4% compared to 1% in the group that got radiation. Is 4% a high enough risk to warrant the added treatment and the added cost and potential side effects?
Right. So I think that that would have to be a decision that you would make along with a patient. I think, you know, given all the studies, I think eliminating radiation for women over 70 with very favorable tumors, I think that's, given the studies and the overall survival, I think it's a good idea. However, if I had a patient that felt strongly that, you know, 4% was way too high for them to take, I would not talk them out of radiation. So I think it's just an individual case, personally.
I think one of the things that we have to be aware of is one of our jobs is to educate the patients, but they also do want our opinion, and then we can go into the shared decision making. But I think that when we're faced with a patient and we're figuring out how to discuss it with them, we do have to have a slant as to what we think we're going to recommend. And then just just give the facts to the patients and say why you think they should do this or why you think they should do that. And then that's when you go into the shared decision making.
Can we have the participants respond to the quick poll that was on the screen? Would recommend radiation. So it looks like 93% of the participants would not, I'm going to say strongly recommend radiation in the scenario of a low-risk tumor, and 7% would. Of course, there's no right or wrong answer to this poll. It's a shared decision. And I do think that we have to be mindful of the number needed to treat to prevent really a recurrence, not so much to prevent a mastectomy. You have to treat a large number of women to prevent the small number of in-breast recurrences. And the in-breast recurrences, as Dr. Goletsky pointed out, can be managed secondarily with further surgery without a detriment on survival.
Those poll numbers are very interesting, though.
Yeah, I agree. If there are any programs that agree with the European position that there is no age group for whom radiation can safely be withheld, I'd be very curious for that program to speak up.
If any program does, you can raise a hand in your panel and I will be able to unmute you.
I'll just give a second for people to respond, and I bring that up because we're going to move on to a discussion about sentinel node biopsy. And I actually think whether to perform a sentinel node at the time of surgery in this population is in some ways linked to whether or not you're going to omit radiation. It may be harder to have the conversation with the patient that you're going to omit radiation if you don't know the nodal status. And that may be part of the reason why the position in Europe is that it's not safe to withhold radiation, particularly if you don't know the nodal status. So maybe
before we get into that, I just have one question regarding the radiation. And so if the shared decision making, I guess, who does the shared decision making happen between? Is it the patient and the surgeon? And are we referring to radiation oncology? And then the patient makes that final decision with the radiation oncologist. Where along the way is that decision being made?
Alana, can we poll the participants for that question as well?
Give me 1 second. Can you let me know how you want the question to be phrased, and I can launch that for you.
I guess let's phrase the question, should all patients be referred to radiation oncology for a radiation discussion?
And these are the patients in the group that we're talking about now. Exactly. Favorable risk over 70.
Because I think Dr. Bogle pointed out appropriately that it's, as physicians, we want to give the patients the data and the facts, but we also want to guide them in this decision. And if as surgeons we would support omission of radiation, and then the patient receives a consultation in radiation oncology, and the stats may be presented in a slightly different way, it may sway them to have radiation that we may have said doesn't offer much benefit. So should all patients be referred to radiation oncology for this discussion? Let's take a minute and see what the respondents say. Very interesting. Very, very interesting. Probably there's no right or wrong answer to this question either.
I agree. I think the result, given the fact that 93% thought that patients should not get radiation, but 59% would refer to a radiation oncologist. And we all have our own definition, and I think that what's important here is working as a team. In my practice, I'm comfortable sending all of these patients to radiation oncology because I think that they're the experts, but I also know that most of them will not get a recommendation for radiation. So I'm comfortable doing that. If I thought that my radiation oncologist would radiate every single person I sent to them, I probably wouldn't be so comfortable sending.
I think it's interesting that, in a poll for just surgeons, we're seeing that 93% would not give radiation. But then when you look at, or when the American College of Surgeons looked at really what are the practice patterns in NCCN centers, and actually 13 NCCN centers, they found that still 88% of women over the age of 70 are being offered radiation, or they're being given radiation. And I wonder if that is also due to the 75% non-compliance rate with endocrine therapy, and if that's part of the discussion that's happening with the radiation oncologist.
That's an excellent point, and the data that Abby showed where patients who are non-compliant with endocrine therapy have much higher rates of not only recurrence but also mortality. And unfortunately, when patients stop taking their endocrine therapy, they're generally beyond the window where radiation would be efficacious. So that is a very important point to emphasize with patients. If they plan to omit radiation, they need to be compliant with their endocrine therapy. I think it's interesting also that you point out that in spite of these data that would support omitting radiation, and in spite of the fact that NCCN has incorporated that in their guidelines, so many women with these favorable tumors get radiation. Something that we saw at the University of Pittsburgh was that clinical pathways for management make a big difference in physician behavior. And the clinical pathways for radiation actually did not address omission of radiation. It is still a consideration, but an example of how pathways change behavior was going from conventional fractionation to hypofractionation, where before the pathway made hypofractionation sort of the preferred treatment, radiation oncologists were still administering the longer-term conventional fractionation, which for older patients is often a challenge for transportation and mobility issues. As soon as the pathway was revised to make hypofractionation the preferred method of treatment, and listing the exclusion criteria, literally overnight the radiation oncologists went to hypofractionation. So, clinical pathways can help implement the findings from clinical trials in a more uniform way, but I think physicians left to their own behaviors have a hard time omitting the treatment that they've been accustomed to giving. Any final comments on radiation? Okay, I think, what's that doing?
Those presentations were excellent, thank you.
They were excellent. I don't know if we can declare a winner or not, because I think both made extremely important points. That there is, Dr. Reyes made the very important point that there are women in this age range that truly benefit from radiation, and when they're outside the eligibility for the CALGB trial or the Prime 2 trial, they should definitely be counseled on radiation. Okay, we'll move on to the second scenario. This scenario is sentinel node biopsy should routinely be performed in women over the age of 70 with stage 1 hormone receptor positive breast cancer and a clinically negative axilla. We'll start with Dr. Arslan Salamat. who is at the University of Pittsburgh Magee Women's Hospital, and that will be followed by Dr. Allison Barron. Dr. Salama? Hello?
Dr. Solomon, I think you might be muted. Can you try to unmute yourself?
Can you unmute him, Alana?
Dr. Solomon, I think you might need to try and call in again. It's showing that you are self-muted and I cannot unmute you. Can you just try hanging up and calling back in again, and you should be able to then be heard.
Or we can start with the second presentation.
Let's do that. Dr. Barron, are you prepared to go ahead with your presentation?
Dr. Barron, I think you might have this issue with Salamat. If you could just try hanging up and calling back in again, and then you should be able to speak.
Okay, we apologize for the technical difficulties here.
Can we hear either one of them?
Yeah, Dr. Salamat, can you try speaking? I think you are unmuted now.
I see Dr. Salamat is signed in twice. They may have to close out.
Although it states that they're unmuted now on that.
I'm in contact with Pittsburgh, and they're trying to log back in again right now.
Can you hear me now? This is Allison.
Allison,
we can.
Yeah, Allison, why don't you go ahead with your presentation? We're having trouble connecting back with Pittsburgh.
Sure. Okay. So I am against sentinel lymph node biopsy in women over the age of 70. And I first wanted to start off with two cases. If I can try and advance my slides here, let me see if it'll work. Do I have the controls?
Yep, you should.
Very good. So first case is a 79-year-old female who a mass was identified on screening mammogram, and on diagnostic mammogram confirmed a 1 centimeter mass, on ultrasound 8 by 7 by 5 millimeters. Biopsy proven invasive ductal carcinoma grade 1, strongly ER/PR positive, HER2 new negative, with a Ki-67 of 4.8%. This patient is fairly comorbid with hypertension, diabetes. She's had a stroke and an MI before. This is a representative mammogram, a post-biopsy mammogram with clip in place and ultrasound. So I'm going to move to the second case, which is a 71-year-old female who self-palpated a mass. On diagnostic mammogram, it was 3 centimeters. on ultrasound 28 by 22 by 15 millimeters, and this was biopsy-proven invasive ductal carcinoma grade 2, also ERPR positive, although not as strong, HER2/neu negative with a Ki-67 of 25%. She has diabetes and hypertension, which are both well controlled. So hopefully we can answer whether or not we think sentinel lymph node biopsy would be pertinent for these two cases. So first I wanted to discuss this SSO Choosing Wisely guidelines. So the American Board of Internal Medicine approached several national societies to come up with some sort of recommendations that would help with healthcare cost expenditures. So the SSO put out 5 guidelines that they felt were appropriate. And the first was, don't routinely use sentinel node biopsy in clinically node-negative women over the age of 70 with hormone receptor positive invasive breast cancer. So they came up with this following the rationale that hormone therapy is standard of care for women with hormone receptor positive invasive breast cancer, and that really sentinel lymph node surgery has no impact on local regional recurrence nor breast cancer mortality. So therefore it's safe to treat these patients over the age of 70 with hormone receptor positive, clinically node negative breast cancers without surgical axillary staging. So 2 of the papers that they cited when they came up with these guidelines, we've already discussed LGB 9343 in terms of patients getting tamoxifen with or without radiation. However, even though this study wasn't really designed to evaluate axillary surgery at all, 32% of women did have an axillary lymph node dissection and 62 did not. With the Martelli study out of Italy, this compared axillary lymph node dissection versus no axillary dissection, again, in women over the age of 70. In both of these studies, there was no difference in local regional control or overall survival with axillary lymph node dissection, keeping in mind that these were predominantly T1 tumors, over 90% of them were. And this was in the era prior to sentinel lymph node surgery, so they didn't evaluate sentinel lymph node surgery, which has a lower morbidity. And interestingly, in the Italian study, there were very high rates of positivity, even in those patients with a low T stage. So one of the breast fellows here at Mayo Clinic last year wanted to delve into that a little bit deeper, looking at larger database than CDB and the Mayo Clinic database. So she included all women with invasive breast cancer over the age of 70 that were hormone receptor positive, clinically node negative, excluding those patients who had neoadjuvant chemotherapy, recurrent disease, and metastatic disease. In the NCDB, there were around 125,000 patients in this cohort, and in the Mayo Clinic, about 667. And of those, there was no axillary surgery performed in about 14% in the NCDB and 8.8% here at Mayo Clinic. And looking at that cohort, the women who did not have axillary surgery, the significant factors that were associated with that were older age, lower T stage, and those were already self-selecting patients that did not need axillary surgery. The overall nodal positivity rate in these women were 14.8% and similar in the Mayo Clinic data. And when stratifying those node positive patients by clinical T stage and grade, they saw that with increasing T stage, there was increasing rates of nodal positivity. And right at the T1C mark, that's where you see the 14% and above. And you see a similar trend in the Mayo Clinic data. And by grade, starting at grade 2 and higher, we see increased rate in nodal positivity at 16%, similar with Mayo Clinic data, although smaller numbers in the grade 3 group. So this is kind of a bar graph trying to see what the influence of the combined T stage and grade has on nodal positivity. So we see the NCDB data on the left side of the screen and the Mayo Clinic data on the right. The T stages are various colors on the bar graph, and the nodal positivity rates range from 0 to 27%. Now this line kind of drawn across at the 10% mark helps us see what are the high-risk patients and what are the low-risk patients. So focusing on the grade 1 columns in column 1 and 3, column 1 and 3, the grade 1 patients, you see that those bars that fall below that line are the T1A through C, so those patients with less than 2 centimeters in size, grade 1. And then looking at the grade 2 patients in columns 2 and 4, the 2 bars that fall below that line are T1A through T1B. So that's those patients with less than 1 centimeter size tumors, grade 2. So just to reiterate, the low risk criteria would be those patients with grade 1 T1A through C or 2 centimeters and grade 2 T1A through B 1 centimeter. And looking at it with this neat little pie chart, you see that both with the NCDB data and the Mayo Clinic data, these low risk patients, nodal positivity rates are actually fairly low at 7%, compared to those patients who meet the high risk criteria, which are grade 3 tumors, T2 and above, and grade 2 T1C tumors. The nodal positivity rates jump to about 22%. So when comparing the nodal positivity rates between the high risk and the low risk, it's really 21% versus 7, or a relative risk of about 3, which is 3 times higher rates of nodal positivity in those high risk patients. So the summary of this paper was that really the overall risk of nodal positivity by NCDB data and Mayo Clinic data is about 14 to 15%, and this supports the SSO guideline to avoid routine sentinel lymph node surgery. So further stratifying by grade and T-stage separates the women into this low risk and high risk group, with the high risk group really having a 3-fold increased risk for nodal disease. So how do we place this into practice? So we have a 70-year-old female with hormone receptor positive invasive breast cancer. If her tumor is grade 1 and less than 2 centimeters, or grade 2 less than 1 centimeter, we say that it's safe to admit sentinel lymph node surgery. However, anything else, that's a candidate for sentinel lymph node surgery, but we really have to consider the patient's comorbidities and how the nodal staging would impact the adjuvant treatment. And as an aside, there was some additional work done by the Pryor Breast Fellow that looked at multivariable model, which showed that age and HER2 status were not associated with nodal positivity, but histology was, with higher nodal positivity rates amongst those patients with lobular cancers and invasive mucinous cancers than, mammary cancers than ductal cancers. And there was a nomogram developed, however, I didn't include it in these slides, but to help calculate the risk of nodal positivity. So looking back at the 2 cases, this first case with patient with a T1 tumor, grade 1, has some comorbidities. We would say that this would be a patient you could admit sentinel lymph node surgery on. But this patient with a larger tumor, a grade 2, less ER/PR positivity, and not very comorbid, you would consider doing a sentinel lymph node surgery in this patient. And that's the end.
Okay, thank you for that excellent argument that it would be safe to omit sentinel node biopsy. I do find it interesting, but while Dr. Salamat is getting ready for the presentation, that there's some comfort in omitting sentinel node surgery, even if the risk of node positivity is 7%, where we worry about the risk of in-breast recurrence being 4%. I think we want to be consistent about setting our threshold for where we feel that intervention is indicated and be fairly consistent. I mean, both of those are less than 10%, which would be considered a low risk. Is Dr. Salamat ready for his presentation?
I'm ready. Can you guys hear me now?
Yes, I think you're back online.
Dr. Salamat, you're a bit echoey. Maybe turn off the sound on your computer just to make sure everything is just through your phone.
Can you guys hear me now?
We can hear you. We're getting an echo. Do you have your phone on or just the computer? Can you go ahead?
I think he's just trying to reconnect right now. Hold on a minute.
While we're waiting for him to reconnect, one interesting piece of information that's missing from the prior presentation, and I think also Dr. Salamat's we will see, is whether use of oncotype testing would influence the need to perform a sentinel node biopsy or not. And I think if you're talking about a healthy patient over the age of 70 for whom you would consider systemic chemotherapy, is nodal staging more important, or would oncotype testing guide that decision? Alana, maybe we can phrase a question to the participants whether the results of oncotype testing would be used to make systemic therapy recommendations regardless of sentinel node status.
Hold on 1 minute and I'll get that up.
Terrific.
Once that question is done, if we cannot get to the presentation yet, perhaps we should run a question as to whether or not, before the presentations are complete, you would do a sentinel node in a low-grade patient over 70.
So the question is, would oncotype testing be used to make systemic therapy recommendations regardless of sentinel node staging? Again, we're talking about women over the age of 70 with favorable ER-positive breast cancers.
Hello?
I think you're back on. We're just getting asking a question of all the participants.
Can you guys hear me now?
We can. It's much better. Give us 1 second, Dr. Salamat. We're doing a poll.
I apologize.
It's okay. Very interesting. So we have not quite a 50-50 split. 45% of participants would use oncotype testing, and 55% they would not. Alana, let's put up the question that Dr. Bulbul asked before Dr. Salamat goes to his presentation. How many participants would routinely perform a sentinel node biopsy in this scenario of older woman with a hormone receptor positive breast cancer? Okay, so right now, it's very interesting. Now, to be fair, Dr. Barron got a jump out on this by being able to give the presentation before we ask the question. So why don't we go to Dr. Salamat's presentation to hear the other side.
Okay, great. So the debate today encompasses the question of whether a sentinel lymph node biopsy should be routinely performed in women over the age of 70 with stage 1 ER-positive breast cancer and a clinically negative axilla. And we believe that, yes, in fact, it should be routinely performed in this patient population. Before we start, let's remind ourselves that women aged 70 years and older are one of the fastest growing segments of the U.S. population, and that breast cancer is relatively common in this age group, with prevalence of nearly 400 cases per 100,000 women. It's also important to note that very few randomized trials actually include this age group in their findings, and that most 70-year-olds in the U.S. have a life expectancy of 13 years or more. Finally, it is important to distinguish between chronological age and physiological age. If we are willing to use 70 years of age as a cutoff for a procedure such as sentinel lymph node biopsy, then why can't we use 60, 50, or even younger as a cutoff? With those facts in mind, the presentation will focus on three central points. Number one, that there is disparity in care of an elderly breast cancer patient, and in most studies, the elderly age is defined at 70 and above. Number two, that this disparity in care leads to understaging and undertreatment of this population. And number three, that efficacy of adjuvant treatments in this age group, whether it be chemotherapy, hormone therapy, or radiation, has been well documented in the literature. First, we would like to take a look at the following chart, which shows breast cancer death rates for the U.S. population from 1980 to 2007. The solid lines represent the group-specific linear regression estimates and clearly demonstrate that the patient population above age 75 has the lowest drop in overall mortality as marked by the red arrows. This is while younger cohorts have seen better gains during that time period. If you look at this graph, this is another depiction of the previous graph, and as you can see, the largest decrease in breast cancer death rates was noted in women aged 20 to 49 at 2.5% per year, and the smallest decrease in breast cancer death rates was noted for women aged 75 years at 1.14% per year. This percentage rate change was relative to the age-specific death rates in 1990. Another study published in 2017 evaluating the SEER-18 database demonstrated that once again, old age at breast cancer diagnosis was an independent factor for worse outcomes in terms of overall survival and breast cancer specific survival. So then the question becomes, why is it that older women have not experienced gains and improvement in breast cancer specific survival and overall survival as compared to younger cohorts? This study by McCarthy and colleagues, titled Breast Cancer Among the Oldest Old, included 49,000 women with stage 1 and 2 breast cancer, 29,000 of which had stage 1. Median follow-up for this study was 5 years. They showed that with increasing age, patients were more likely to have staging information missing, and stage imputation shifted the elderly patients into higher stages. Increasing age, therefore, meant that patients were more likely to have larger tumors, more likely to not have nodes examined, and more likely to have positive nodes. In addition, elderly patients were less likely to get standard care. In this study, in patients over 80, only 66% received breast conservation surgery and radiation, and increasing age increased the likelihood of single modality approach to care. In conclusion, it appeared that patients were treated primarily based on chronological age rather than existence of comorbidities and frailty. The relationship between lymph node involvement and age has also been reported in other studies, including this study by Nevin and group. Their study evaluated 2,227 patients with early breast cancer, and they simultaneously analyzed the second large population-based database. They demonstrated bimodal distribution of lymph node involvement in two separate databases, where women up to 70 were less likely to have positive lymph nodes with increasing age, and women over 70 were more likely to have positive lymph nodes. In addition, They showed that age correlated with tumor size, and that smaller tumors were more likely to have lymph node involvement. This is yet another study that examines the reality of undertreatment based on chronological age. In this study, the ELIPS 65 database in France was examined, and 223 women aged 65 and above were identified who were eligible to receive chemotherapy according to the French national guidelines. When offered chemotherapy, only 3 women refused chemotherapy, as demonstrated here. The analysis showed that majority of patients had stage 1 tumors, a majority were ER-positive tumors, and 47% had lymph node involvement. When evaluating for those who actually received chemotherapy and adjusted for comorbidities, only 35% of 75 and above patients received chemotherapy, as compared to 60+% in the 60 to 69 group. Age was therefore once again the only characteristic that showed a significant p-value between the groups. The takeaway from this study was that after adjustment for comorbidity score, tumor characteristics, socio-demographic characteristics, increasing patient age was independently associated with decreased guideline concordance for adjuvant chemotherapy. And women aged 75, 80 received adjuvant chemo 4 times less than their younger cohort. Another very important takeaway from this study, and very relevant to today's discussion, as mentioned by previous speaker, was that in this cohort, non-persistent to endocrine treatment went from 8.7% at 1 year to 24.7% at 4 years. Another unique characteristic of this study was that the effort to create oncogeriatric coordination units helped increase the percentage of women receiving chemo from 33% to 58% in 2 years. We therefore have so far established that patients are understaged and undertreated, and that this leads to a treatment bias based on age. So are there great opportunities to achieve better outcomes in women over 70, and are we denying the older cohort of these opportunities by attempting to omit a simple procedure such as a sentinel lymph node biopsy? So let's focus on the efficacy of adjuvant treatments by reviewing this study by Norton and colleagues titled Adjuvant Chemotherapy in Older and Younger Women with Lymph Node Positive Breast Cancer. This study included 6,487 patients with node-positive breast cancer and collected data from 4 randomized controlled trials. Once again, 33% of tumors were T1 tumors and 40% of the tumors were ER positive. They therefore demonstrated that in elderly patients, disease-free survival improved with more chemotherapy, and that overall survival also improved with more chemotherapy in the older cohort, and they drive the same benefit as the younger cohort. In conclusion, older and younger women drive similar deductions in breast cancer mortality and recurrence from regimens containing more chemotherapy. In conclusion, we should continue sentinel lymph node biopsy in women over 70 so as to not perpetuate a well-documented healthcare disparity. Number 2, elderly patients can derive benefits from adjuvant hormonal, chemo, and radiation therapies when staged appropriately and undertaking risk of general anesthesia and sentinel lymph node biopsy. Sentinel lymph node biopsy by itself adds minimal time to the index operation and can be performed efficiently. There's also minimal risk with current radio tracers and dyes that are being utilized, and risk of complications such as lymphedema are as low as 5%. And finally, although all patients with a positive sentinel lymph node do not require chemotherapy, some may benefit from axillary interventions such as radiotherapy, additional axillary surgery, or further surveillance. These are my references, and I wanted to thank Dr. Keenan, Dr. Johnson, and Dr. Diego for helping out.
Okay, that was an excellent presentation, and I think you made some incredibly important points about management of the breast cancer in the elderly, particularly that withholding recommended treatment when it's appropriate can significantly impact their outcome. I want to be sure, though, we keep our conversation focused on women over the age of 70 with small, biologically favorable tumors, because I think we all agree that when we're seeing a woman over the age of 70 who has a triple-negative breast cancer or a HER2-positive breast cancer, regardless of sentinel node status, if their health would allow it, if they don't have too many comorbidities, we will seriously discuss systemic therapy with them. But in this particular group that we're focused on tonight, how much does a positive sentinel node change recommendations for their treatment? And I think we need to look at it in terms of how much would it change recommendations for local regional treatment, and how much would a positive sentinel node change recommendations for systemic therapy. So why don't we maybe take those one at a time. And I think polling is a good way to do this rather than going one by one, because I don't want to single out one group over another. But how many programs are using Oncotype testing in this population of women who have a positive node, a positive sentinel node? Can we put that up there, Alana?
Give me 1 second and it'll launch.
And again, we're focused only on women over the age of 70 with ER-positive breast cancer and small primary tumors.
I just want to be aware of time. We have about 13 minutes left.
Yeah, I see. Thank you. This one should be wrapping up momentarily. So it looks like about 2/3 of the participants would use Oncotype testing if the sentinel node was positive, and a little over 1/3 would not. And so I think it's reasonable to ask the question, since the median number of positive nodes in this population is 1, is the sentinel node necessary if Oncotype testing is going to be used for making systemic therapy treatment decisions? Susan, do you have any comments on that?
Well, I'm actually interested, just to back up, because I was just going to ask you if you were surprised by this result. You know, the 60-40 split.
I'm not too surprised by it. Are you surprised that so many people would use Oncotype?
Well, I'm trying to figure out what it means. Does it mean that they're giving endocrine treatment, or are they giving chemo and not using it? I'm not sure what it means.
So
I suspect it means that those patients are getting endocrine treatment alone, but I'm not sure.
With a low-risk Oncotype score, I suspect that's what we're looking at.
Right, but I'm saying if they're not getting Oncotype, because 40% are not getting Oncotype. So are those patients getting chemotherapy, or are they just getting endocrine treatment?
So let's put the question out there then to the participants. For the participants that do not use Oncotype when the Sentinel node is positive, is chemotherapy being recommended to these patients?
I guess to answer the question is, I'm surprised that it's not a higher number. I mean, there's a difference of over 70 and over 80, but in New York, I can tell you, I have 70-year-olds who are training for the marathon next month. A lot of them. So it's to say to a patient like that, oh, you have a positive node and I'm not getting Oncotype, that's a big difference.
See what the response is here. So, one of the goals of this webinar was really to tease out differences in treatment across the country, and this really shows that there are substantial practice variations across the country in managing women who have what looks biologically like favorable breast cancer. And certainly it looks like there are many programs, at least 40%, that still use nodal status as the primary indicator for recommending chemotherapy, even in this age group. I know that
in your practice, woman over 70, good performance status, has a positive node. What's your institution's practice on that patient?
So I will answer that question based on my current institution, which is the University of Colorado, where the medical oncology group is using nodal status as opposed to Oncotype or Mammoprint for patients who are healthy and able to tolerate chemotherapy. But that was not the practice at the University of Pittsburgh, and I know we have participants at the University of Pittsburgh who can weigh in on this. At that university, Oncotype was regularly being used, or another genomic assay, to determine whether there would be a benefit to systemic chemotherapy above and beyond endocrine therapy for this specific population.
Yeah, I would say at my institution, which is Mount Sinai Beth Israel in New York, we would, given the fact that the patient had a good performance status, we would use a genomic assay. We typically use 21-gene genomic assay to determine the systemic treatment for this patient.
Are any of the fellows at the centers that would recommend chemotherapy to these patients, would any of you type in a message or be willing to comment on how those decisions are made at your program for this population?
And feel free to use the chat, or you could raise your hand and I can unmute you if you want to discuss verbally.
So while we're waiting, there's a question from a participant saying, it was my understanding that Oncotype is not covered yet by insurance until you have nodal status or nodal surgery. That is not the case in my experience at all. There are many patients, in fact, about a third of Oncotype specifically, because I know about that assay, is done on the core biopsy. So clearly they do not have nodal status when it's on the core at that point. So you do not need nodal status for that, for insurance to pay for it.
So Dr. Bowie is participating, and why don't we unmute the microphone for Mayo Clinic so she can comments.
Hi, Susan and Gretchen. I would just say that, for luminal A tumor in a lady over 70, our medical oncologist, I don't think would give chemotherapy. If you got a Ki-67 of, 3% and a grade 1 tumor, even if you did identify a positive sentinel node. Now, I think if you're talking about a luminal B tumor, it's a grade 2 or 3, you got a higher grade and a higher Ki-67, then I think we may consider oncotype. So I think, a generic question in a woman over 70 with an ER-positive tumor still leaves open to interpretation grade, size, and tumor biology a little bit, and that might be why we're getting some varying percentages on the responses.
I agree. That's really why I specifically asked about oncotype, because not every institution classifies tumors as luminal A or luminal B in a consistent way. I know in Pittsburgh we developed a series of equations that helped us to predict the oncotype score, and if the tumor fell out to be a low-risk score, oncotype testing was not necessary. Whereas if it looked like it was going to be a higher risk score, we would order the test. But I don't know across the board if every participating site has a consistent pathology report that helps them classify tumors as luminal A or B. But you may be right, that may be why we're seeing a disparity in whether chemotherapy is being recommended. This is a heterogeneous.
Grade and ER ranks might give us some indication, even if you don't have the Ki-67. So, I mean, maybe for the questions we could limit to grade 1, high, strongly estrogen receptor positive, and then flip it to, grade 2, intermediate estrogen receptor positive.
That's a very, very good point. I don't know if we'll have time to put up all those questions, but I do want to get to one other question, because we started the evening talking about whether it was reasonable to omit radiation. And I guess an important question is, does nodal status influence that recommendation to omit radiation? Can we put that question up there?
Gretchen, can you repeat that for me, and I'll get that right up?
Yeah, sure. Is sentinel node biopsy status necessary to omit radiation therapy? Really getting to the question, if you knew a patient had a positive sentinel node, would you be inclined to recommend radiation even with favorable tumor biology? Very interesting. I mean, the data would support that you don't need it if the axilla is clinically negative. But I think getting to Dr. Salamat's presentation, that knowledge of a positive sentinel node may influence further local regional therapy recommendations, I think is worth considering. Any other comments or questions from the participants?
Yeah, Gretchen, Judy again. I'm going to be controversial. Our National Society of Surgical Oncology came out with this guideline. Am I hearing that none of the centers across the U.S. support the recent guideline?
Are you talking about the SSO guideline to not routinely perform sentinel node biopsy?
Correct.
I think we're getting input that some centers are supporting that. At least 36% of the respondents to the last question would omit sentinel node biopsy in this favorable population. I think the paper that your fellow gave, or the presentation your fellow gave, is very useful in identifying which patients are the low-risk patients, where the likelihood of a positive node is 10% or less, helps drive that guideline into selecting the patients where it's most safe to omit it, and then having the conversation with more high-risk patients about why their nodal status is more important to investigate. I mean, I think all of the presentations that we've seen tonight have gathered data that can support either position, but it depends on which patient population you're looking at. You know, the first presentation looking at omission of radiation, the patient was not someone where I think most centers would be comfortable omitting radiation. And then the presentation that Dr. Barron gave with the two different patients really highlighted that we have to be selective about when we're willing to de-escalate therapy, and nicely illustrated when we should omit the biopsy, the sentinel node biopsy, and when we probably should consider doing it. And I think even the SSO supports not routinely doing it, but there are some patients where sentinel node biopsy remains appropriate over the age of 70.
And I think Dr. Parma has a question, if we wanted to go answer that if we're done with this.
Sure, go ahead.
Dr. Parma, you're unmuted. Okay. Well, I can read her question or comment. She said, I think if you are going to do sentinel node biopsy, then we would argue that you plan on acting on that should it come back positive. If you aren't going to offer adjuvant therapies, then why do the biopsy and potentially have morbidity associated with it?
Excellent point. And those are the conversations that should take place in the office prior to surgery happening, and often in a multidisciplinary environment. Okay, I think with that we better wrap up the evening. I want to really thank all of the fellows that put together excellent presentations as well as the reading list, and Dr. Bulbul and Dr. Bowie for weighing in. I hope everyone found this to be an educational experience. We have another webinar scheduled in November. The topic will be pregnancy-associated breast cancer, and we'll be looking for volunteers for presentations for that webinar, so please stay tuned.
Thank you, everyone. It was excellent. Thanks, Gretchen and Judy and Alana and Joseph. Thanks.
Thank you all. Have a great night.
Okay.